So Jennifer Breira and Karen Linkins have been initially Desert Vista, correct?
You still are.
Oh, you still are?
Businesses, many things.
Oh, okay. But they're now, I know them as Integrated Behavioral Health Partners, and they've been working with a number of the counties that are here today over the years, and we're really honored to have them work with us today to pull together some of the concepts and ideas that you were presented with, and for us to have a dialogue together about those different things. So thanks so much for joining us. Really appreciate it. And thanks to Blue Cross, I believe, Blue Shield, sorry. Blue Shield of California for funding us today. Thanks.
Great, thank you. I'm Karen Linkins, and this is Jennifer Breira. And what we were asked to do today was to just give some high-level reflections of what we heard this morning, because we heard a lot, and it's the work that you're doing is so fantastic that we actually think that it speaks on itself, so you won't hear that much from us. But then we also wanted to use this opportunity to structure your conversations at the table. And so we do have some questions that we're going to pose at the end of these brief remarks, and that can hopefully inspire your lunchtime discussion. And then we're going to do a report out afterwards, but we'll explain that in a minute. So I just wanted to start by saying that one of the things that really struck me today is that I think Jennifer and I have been working in Santa Cruz it's well over a decade at this point, and we've been working in some of the other counties as well, or we've heard of the work in the other counties. And one of the things that really struck us today is how the narrative has changed, and it's changed so rapidly. You know, in the last 4 years, it's like the integration genie is out of the bottle, and integration is no longer trying to integrate behavioral health into primary care in the four walls of a clinic. Integration is actually systems change, and integration is all about putting the person first. And it comes through so strongly and loudly in the way that you talk about this. And one of the things that is really exciting too is the narrative has really shifted to really embrace the social determinants. And it's not even just talking about the social determinants. Every single presentation was actually operationalizing the social determinants. You know, whether we're talking about housing was in every presentation. And then even things like, you know, getting into employment, like with WRAP, the Wellness Recovery Action Planning, and moving into social supports and addressing stigma, and the whole issue around access to food and nutrition and transportation. I mean, all of these issues were really woven into all of the programs that were presented today.
In working with Integrated Behavioral Health Partners, which as an organization is a virtual team of consultants around California doing this work, we started off as IBHP, which was Integrated Behavioral Health Project, because it started as a project, as a pilot. And then it grew to partners, and I think that that's really emblematic of how integration has changed through the years as well. And I was very pleased to know that we were both taking notes throughout the whole morning, and when we compared our notes briefly, we were on the same page, so I guess that's why we work so well together. But I really think of integration shifting towards really what you've been describing is community integration. And that involves many, many things. It involves expanding your partners beyond just the healthcare sector. It involves really intentionally bringing in your community and the residents, not only to elicit from them what are their needs, but to have them have a meaningful role in designing what the interventions are going to be, and then feeding that information back to them. And then I think one of the most exciting opportunities in healthcare, not just integration, is the role of non-licensed providers in this workforce, and the role of community health workers, and I was just going to say that people with lived experience, whether it's mental illness, homelessness, just the struggle it takes to navigate our incredibly complex healthcare systems and, you know, insurance, that those experiences and that commitment and that passion that individuals who are non-licensed providers are going to bring, that's what's going to make the difference in healthcare. It's really the crucial an essential ingredient for all of the systems to reach the outcomes and the goals that they want to achieve. The other thing that I wanted to talk about, because we're data people and evaluation and that sort of thing, but just the conversation around technology and data and outcomes, it has both a positive and a negative, right? I mean, there's so much emphasis on tracking your outcomes and all of that, and that is, of course, super important to payers and all of that. But the process that you all are going through to change your systems is equally as important to track. And we have had the opportunity, the privilege of working with Kathleen Grossi in Merced in mapping the workflows. And you see some of that in your packet on the left-hand side. We kind of took that real-world field experience and translated into some documents that could be used for any community on tracking referral pathways and care coordination points and communication. And it's important to know how it's done and then also what is the outcome. And so we just kind of wanted to emphasize that was something that we heard as well too, that understanding like the how is as important as what happened. And then I think you wanted to talk about the change in evaluation to rapid cycle.
Yes, well, so there is that, but I also wanted to just touch on the communication piece, because one of the things that we didn't hear today that is fantastic is that communication is a barrier. We didn't hear, oh my gosh, 42 CFR, HIPAA, blah, blah, blah. What we heard was, we've actually figured this out. And I want to congratulate all of you for pushing through that with your strategies, because that is such a game changer. And it's really how we do the systems transformation. The other thing that I want to acknowledge is 10 years ago, we would never have been talking about the health plans. And the health plans are front and center in all of these initiatives as well. And I can't tell you what a difference that makes, because when we think about sustainability, which we also heard about, which is really, really fantastic, you're not seeing these as programs, you're seeing these as lasting changes that you want to sustain. All of the entities in the community, like the health plans, like the Medi-Cal programs, different things like that, need to come together for that. And it's great to hear that you're not just going grant by grant by grant. You're actually looking for return on investment, making the case, using evaluation findings or outcomes, tracking outcomes to demonstrate that, and to really understand, how can we do cost offsets and look for dollars in different ways and demonstrate value. And that's huge. And I can't believe that, well, I can believe, because you're a community of amazing people, and you're doing amazing work, but the change is so fast, because we were not talking this way in 2012. So we can thank the ACA. We can also thank a lot of other things. So congratulations.
The other thing I wanted to mention as an observation that I heard, and part of the work that Karen and I have done as IBHP for many years was funded through Cal MHSA, which is another remarkable contributor to systems change in California. And we were specifically funded under the stigma and discrimination reduction component of MHSA. And it was around the state, and MHSA had a recognition that integration is a strategy for reducing stigma and for, increasing access to healthcare and behavioral health and addictions treatment for people who wouldn't necessarily go to the systems of care that existed. And so trying to access that through primary care. And so the work that's being done, the huge lift that's happening on the primary care side to advance and elevate their confidence and capacity to address mental health, depression and anxiety and the stuff that they see in primary care, now shifting into medication-assisted treatment in primary care and really treating addiction as any other chronic disease is significant. So the fact that, we're hearing the advancement of that in all of the communities that presented today is really impressive, and measuring changes in stigma is incredibly hard, but having that as part of your narrative in the work as an outcome, an actual outcome you're looking to track in terms of how you're getting more PCPs to buy in and the number of X licenses that are being issued in a community that speaks to the capacity change is also really important. So we're always thinking about the balance between the systems level work that happens, but how do you translate that into actually communicating outcomes to various stakeholders, because it's very important.
So now it's your turn. So see the questions, the discussion questions. We have 5. So what inspired you today? What activities or approaches would you consider implementing in your location? What changes would you make to your data collection approach or outcome measures based on what you've heard today? What similarities can you identify across programs? Are there common challenges that need to be addressed? And then what policy level issues were identified that create challenges for behavioral health integration? And what we'd like is, now, is there a worksheet, Shelley, or is there something?
Those questions are also, there's a couple of papers on the table to view. And then I would lead us back to this mapping exercise. Yeah. Now that you've heard all the complexity and details from the presenters, to try to fill in some of this mapping. And admittedly, that's no small task, and of course it is somewhat county specific, but a lot of these infusions of new programmatic resources are federal. So they're sort of universal, and that's why we include a timeline. So use your time with your colleagues is my request.
And then we'll let you eat, but you have to talk while you're eating. And
right.
and then at, I guess, about 1 o'clock, is that right? 1 o'clock, we will we'll come back together and we'll do a quick round robin to get some of the high level comments from your discussions. And I also want to, before we end, I want to acknowledge the work that HIP has done over all these years. Because I think that, you know, it's been very visionary to be able to leverage grant dollars in a very strategic way, and I think that, you know, in this region we really have to acknowledge that. So
a half an hour for conversations, eating, a little bit of documentation, and then we'll do the round robin report out at 1 o'clock. We are going to take about the next 15 minutes just to kind of give the floor back to all of you and have you share with us kind of what the nature of your lunch conversations were. Maybe they addressed one of these questions, maybe they addressed other interesting questions, but we definitely wanted to kind of close out the day in hearing from all of you kind of what your reactions were to this morning's presentations and having the opportunity to network and speak in greater depth with one another. So we have some mic runners around the room. No structured format, except maybe we'll start with this table.
Hi, so we spoke a little bit just about some of the services that we're doing and some of the twists that we heard on new ways to approach those services. For example, integrated MAT being located in the ER was something that was really interesting to us. It gives us sort of a different perspective on how to operate those services. So I think that's what we felt we were most inspired by, was kind of take a different approach to the work that we're doing.
Great, thank you.
Our table, everyone's from Santa Cruz, so I think we were very focused on how to bring some of the cool models of care to Santa Cruz, and I think there's a focus on, we have some of these things in place, but we don't have that focus on engagement, and talked a lot about how we could accomplish that in our county, including the sort of peer navigator, community health worker position, role.
We spoke about quite a few things. And when you think about all of the different counties and the resources that are available in the county, Merced County is difficult. It's difficult to get physicians in that county. It's difficult because of how spread out things are. And then we also talked about there's so much focus on opioids, but what about the other drugs for substance use disorder, methamphetamine? Different counties have those issues, and how do we solve that? And then, so we didn't really stay on topic with the questions, as you can tell. And then the other thing we talked about is with the opioid and getting physicians to get their licensing. There's the behavioral health component that comes with that. And so you can have 1,000 physicians with the X license, but if these physicians, they don't have the time, they don't have the resources for the behavioral health component of it, and how do we address that? And how do we help physicians with the resource for that behavioral health component that goes along with that X license? So, and then what was mentioned at the beginning of this is you can take the horse to water, but you can't make them drink. We've got all of these resources. If that individual is not willing to participate in recovery, whatever you want to call it, so there's a lot of, there's wonderful programs, but we still have barriers for supporting so many things that are well-funded, pretty well-funded at this point. So.
I've had the privilege to work and teach in behavioral health in the Netherlands. And part of that was exposing nursing students from the United States to healthcare in Germany and in the Netherlands. And today, the most moving speaker to me was Jason. And I really believe that if there was a way that we could have housing first and not have hoops for people to jump through that are impossible for them to ever accomplish these things, I think that we could really make progress. I'm from a red state, and I'm happy to be in a blue state, and I have always been so excited to be in Monterey County because it's a size of a county that can really rock this, and the state of California, I know, can do it. So I think the more we work with addiction and and taking away the stigma of that and mental health, the more progress we're going to make.
I just wanted to respond to the horse and drink concept. What I heard today that really moved me was the many touches that are part of recovery, and that recovery is not an instant like switch. And so what I learned is keep being there, keep being present, and people will, when it's the right time, come around. And I think the not being hurt by a no, that was a really good thing for me to hear. But I think the water still has to be there for the horse to come when it's the time. And so I've really shifted my, so I've started a mindfulness practice, or been doing it for a long time, but starting to teach. And I think that recovery is a lot like sitting, and you sit, you're saying you're focusing on your breath, and then all of a sudden your mind is somewhere else. And you kindly, gently, with love and kindness, come back to your breath. And I think recovery is very similar. All of a sudden, there you are. You're using again. Be kind and gentle, and come back to your, what is your breath, whatever the equivalent is for you. So thanks for bringing up that image, because I think we can't be discouraged by that. That's just the way it is. Yeah, I know. I don't want to promote discouragement, but I think, so we're a health plan, and how do we help? I mean, we've got just being there, still being there, still doing the right thing.
While we're working on metaphors, I love that extrapolation. I think sometimes the water has to change size, shape, color too. And so one of the conversations we were having is about being creative with how solutions are offered, right? We were talking with the two ladies that had to go, but so I know it was mentioned about 42 CFR and federal regulations around confidentiality, managing substance use. One of the things that I learned when we were early in this process that I was so excited about is that, and you all should know this, if you work in substance use fields and are under 42 CFR, in a medical emergency, you can break confidentiality to talk to providers, even if you're regulated under 42 CFR. So when we're in the hospital and somebody's having a medical emergency because they're in emergency services, psychiatric or regular, we break confidentiality like crazy, and we are not unduly, but we're reaching out to their psychiatrists, we're reaching out to their therapists, we're reaching out to case managers, we're reaching out to whoever we can that we can see in these 5 electronic health record systems. Oh, you saw Dr. So-and-so, you've been going here, you've been going here. We want to let them know, hey, we got your person here. So we do a lot of that collaboration, and that's part of what I mean about changing the size and shape of the water. It's letting people know and being creative in that sense. Because yeah, there is money available, which is fantastic, and how it gets put into place, I think that we have to be very creative about systems transformation, really looking at what is our goal, and how can we make the system fit for the people that it has not fit for decades. because that's what I think, that creativity is such a big piece of it.
That's such a great point. I'm really, really glad that you brought up the reality check that is embedded in the HIPAA and the 42 CFR regulation. I mean, there in both of those regulations, there is embedded in that some common sense that I think sometimes we lose sight of in our systems of care because of our fear around disclosure and personal health information and what does that mean and liability. But absolutely, when you are healthcare providers and you are trying to manage the health of a patient and that patient's in crisis, that's where some of the common sense around, of course you need to find out what's happening with this person, comes into play. So thank you very much for sharing that. I wanted to share something that came up in my lunch discussion, even though we weren't even doing the exercise, but I learned something. I learned something today that I think speaks to what we're all doing, and it's kind of just the massive scope of integration efforts. And you know, Karen and I are fortunate to work in a lot of communities and a lot of systems of care on integration, but one area that we are not that steeped in is the college system. And we were having a wonderful conversation in the back with a woman from UCSC, and what she was sharing with us about the statistics around what's happening on college campuses in terms of addiction, substance use, mental illness. I mean, she was actually saying that we would benefit tremendously from having MAT on campus and intensive outpatient for mental health on college campuses. And this was news to me, but it reminded me that when we're thinking about the expansion in the thinking of what integration and health means, the thinking around, there's a lot of work happening in school-based health, but thinking about college campuses and the full range of healthcare or school-based health, whether it's starting to screen for ACEs, adverse childhood experiences and all of that. But that's another continuum of this work that wasn't formally mentioned in the presentations today, but came up in our lunch, and I thought it was really important to mention. Other reflections, thoughts from your conversations? Okay. So Karen's going to send a little plug out to some things that we're going to do in terms of follow-up with those that presented here today. So,
yeah, so you all got this great experience today, and there is going to be a little bit of a capstone event that results from this, which is that Jennifer and I have been asked by HIP to do interviews of all the speakers today, go a little more in depth about your programs, to look at the extent to which there are common measurement systems or strategies that you're using, different things like that. And then we're going to compile that and then share it with all of you as a product for HIP. I guess this is kind of the capstone of your Blue Shield funding as well. And we don't know, we never know when we start these things what they will look like in the end. But we can promise that A, it won't be a weighty tome, B, it will be useful, and C, it might not be in writing, it might even be a webinar. And so if you have any, insights or any, advice on that, let us know about that as well.
So when you get an outreach email that comes from either of us, from Integrated Behavioral Health Partners, please remember, oh yeah, those women at the end of our meeting at the golf course. That's right. And so if it'll help you to remember this, I actually used to be a golf pro. In my 20s, yes, no kidding. So I came up here and I didn't know whether I was here for the meeting or I needed to get a bucket of balls, but you will be hearing, those of you who spoke will be hearing from us to set up an interview time in the next few weeks. This is a short turnaround project. So with that, I want to thank you for letting us crash your event today and sharing all your great work with us. And I'm going to turn it over to Shelley to close.
Thank you. Aw. So back to my committed request from this morning. I do truly hope that you have new business cards and contact and ideas to take back to your work lives. And I hope that this bit of respite in a gorgeous setting on a Friday afternoon or Friday midday has been helpful. And again, just acknowledging all of the commitment to people that I see really represented in the room today. And the other thing I'll say is that Blue Shield of California Foundation, our program officer, Rachel Wick, agreed to offer additional funding to engage Karen and Jennifer. And I feel very fortunate for that because I feel like there's so much richness in the room. I feel like that will bring it together most fully. And then the last thing I want to say is just to ask all of you who presented, if you don't want me to share your materials electronically as PDFs, please let me know. Otherwise, I will be sharing those as follow-up material as well. And then, as we've seen, we've had videography happening today, so we will get that posted on the HIP website as well. And I ask all of you who were here to please share that with your colleagues who you knew should have been here if they possibly could have. So thank you very, very much. With great humility, I so appreciate your time and engagement today.